letters coming in.
Oh yeah.
Yeah, we don't need it's all casual. It's all right.
Hello. We welcome all the participants from within Canada and around the world. This is the Canadian Epilepsy Teaching Network, hosted by the Canadian League Against Epilepsy. We are excited to showcase monthly virtual rounds given by national and international experts in epilepsy. Sessions were designed based on the survey results conducted among the CLAE members and follow the International League Against Epilepsy competency-based curriculum. Each talk will be for 45 minutes, followed by a question and answer session.
Hi, everybody, and welcome again to another session today. We're very lucky today to have Dr. Larry Hirsch give us our talk today. Dr. Hirsch is a professor of neurology. He's chief of the Division of Epilepsy and EEG and the co-director of the Adult Epilepsy Program at Yale University. He's had lots of leadership positions held throughout the American Clinical Neurophysiology Society, the American Epilepsy Society, and perhaps best known and also, most prolific in the area of critical care EEG monitoring. And he was the founder and actually former chair of the Critical Care EEG Monitoring Research Consortium, which is now grown to over 50 centers. I think you're in for a real treat. Dr. Hirsch often will be the person people look to in these types of talks and conferences. Every time a question is asked, immediate silence, everybody looks to Dr. Hirsch for the answer. So I'm really pleased that he was able to join us. Thank you, Dr. Hirsch, and the floor is yours.
All right, thanks, Tad. It's a very nice introduction, and I appreciate the invitation. Thanks to CLAE, and let me share my screen. Swap that. Get my laser pointer. All right, I think we're all set. So let's get started. I do have a couple interactive slides in the middle, including some quizzes, so you'll have to be paying attention. These are my disclosures, not too many related. Gives me a chance to advertise my atlas. The second edition of this is in press, should be out any day now. All right, so these are our learning objectives: to learn how to use standardized nomenclature when describing EEGs in the critically ill, to know which patterns are associated with seizures and worse outcomes, to understand the limitations of the terminology and the limitations of our current level of knowledge of what to do about these things, and to help do a little better about deciding when to treat or not. Okay, just a couple of real background slides about non-convulsive seizures and why we do all this EEG monitoring in the ICU. This is mostly why, to pick up these non-convulsive seizures. And this is a whole bunch of different studies looking at the prevalence of non-convulsive seizures when you put EEG on these people, either all neuro ICU or all traumatic brain injury, subarachnoid, etc. You see somewhere around 20% or a little bit more of patients are having seizures. And this second bar shows what percent of those have purely non-convulsive seizures. So you need EEG to recognize them. And this is a nice systematic analysis. I looked at the same thing not that long ago. And it's non-convulsive seizures on the left, non-convulsive status on the right. And you see overall, it was 18% of patients had seizures, and half of those qualified as non-convulsive status by the definition used back then, which was really 30 minutes of seizure. And the other important point was they compared continuous EEG to routine EEG and found the rate of detecting seizures was triple, slightly less than triple with the prolonged recording. So this is my summary iceberg slide on that. You will see some seizures that are obvious at the bedside, but for the rest, you have to send your EEG technologist. Okay, so as far as terminology and the ICU, This started way back in the early 2000s with a small group of people. Eventually, through the ACNS task force, we put together a proposal for what to call all these terms, since everyone was using different terms. And initially, it was really just for research. But then, by the time we did another one 8 years later, this became a clinical guideline through the American Clinical Neurophysiology Society on how these should be used in clinical practice as well. Again, mostly just to use the same terms throughout the world, and so you can talk about things and understand exactly what is being seen. This is the latest version. It's about a year old now. Another ACNS guideline. It got much bigger, expanded to more countries and 4 continents. And the good news is most of what you learned in the prior ones, you don't have to forget. Almost none of it was removed or changed significantly. We just added on a lot more definitions, most by popular demand. So as I mentioned, the objectives of all this terminology is to just standardize what we call these patterns so we can study them. It's really meant to be used in any age, but there is a separate neonatal guideline. So don't use this one in neonates. I'm thinking infants, it's not ideal, but there is no separate infant terminology. So this is the whole crux of the terminology, just 2 main terms. The first term tells you the location of the pattern, and the second term tells you what the pattern looks like. And these are really all the options. The only thing added in 2021 was the term unilateral independent. That's 2 different foci in the same hemisphere doing something independently. And you just combine main term with main 2, and that's how you describe all the patterns. Nice and simple. So these are the options for main term 2. I'll give you the definitions. So for both periodic and rhythmic, these waveforms have to repeat at nearly regular intervals, which does have a definition if you want to get quantitative. And the difference between periodic and rhythmic, the only difference is that with periodic discharges, there is an inter-discharge interval. There's a break between each discharge. Take the exact same discharges and shove them together, then they become rhythmic. And then spiking wave is a particular pattern that has to be alternating very consistently from spike to slow wave to spike to slow wave. And that has to go on for at least 6 waves. So for all of these patterns, you have to have at least 6 cycles to count as being present. So if you just see 3 or 4 discharges in a row that look periodic, that's not enough to qualify as periodic discharges. You have to have 6 of them. So just to show the same thing graphically, so this is periodic discharges because there's a break between them, assuming there's at least 2 more. And then you take the exact same discharge with no break and it becomes rhythmic. And this is spike wave with that perfectly alternating pattern. These are examples of rhythmic delta activity. So the classic one is the nice sinusoidal one, but it doesn't have to be that at all. In real life, it looks much more like this top one. It's got other things on top. It's a little bit irregular, might be sharp on one end, might not. It can be arciform. All these are rhythmic delta. This last one is not. It's much too irregular. So this is not, this is polymorphic activity. And that is an important difference because lateralized rhythmic delta activity has a pretty strong association with seizures. The polymorphic one or irregular does not have an association with seizures, just with focal dysfunction. So the rhythmic part is the important one. All right, here's your first quiz question. We're going to have people just put the letters in the chat as the response. We couldn't get the poll feature up and running. So a pattern is considered to be present when it continues for at least blank cycles. Just put numbers in the chat or letters. Excellent. Give you about 3 more seconds. I think you're all seeing the answer. So the vast majority of people said C6, which is correct. E was a red herring because that's for a definition of seizures. Nothing to do with whether these patterns are present or not. 6 cycles. All right, let's keep going. All right, that's your summary. Again, if you get this down, you pretty much have the nomenclature down. The rest is just modifiers. There's no rocket science here. They're just standardized and quantified. The only thing added in the new version was stimulus terminated. Stimulus induced was already there and is much more common for one of these patterns to be brought out by any alerting stimulus. About 15 times as common as the stimulus terminated, but occasionally you'll have a pattern and then you stimulate the patient or wake them up and the pattern goes away. So that would be stimulus terminated. Here's just to show you some examples. I think all my EEGs are going to be left alternating with right and left and right temporal, midline down here. So here you see very regular, about 1 Hertz periodic discharges just on the left. So that's lateralized periodic discharges. It doesn't matter if you see a little bit on the other side as well. As long as it's clear which side it comes from, then it's called lateralized. You can put a modifier of bilateral asymmetric or purely unilateral, but they all fall under LPDs and they all have a super high association with seizures. Here's another example, pretty spiky, even slower than 1 Hertz. And here's one. You see, they don't actually qualify as sharp waves. They're too broad, but that doesn't matter. As long as they're periodic, they're still called lateralized periodic discharges. And yes, even if when they're blunt, they're pretty highly associated with seizures. You look at some of the classic herpes literature, they'll look just like this, herpes encephalitis, these broad, long discharges happening periodically. Here's another example. I put this one in just to show that even if it's spike and wave in each discharge, if there's a break between them, it's still called periodic discharges. Okay, here's one where you see it, periodic discharges on the right and periodic discharges on the left, but they're doing their own thing at different rates. So that's bilateral independent periodic discharges. Here's some examples of generalized one. This one on a totally flat background, usually anoxia. Here's another version, better background. Here's another one. This one is compressed a little. You see something happening every 5 seconds or so. So in the critically ill, you have to be very careful about anything happening every 3 to 5 seconds, particularly when they're ventilated and it's really regular. This is actually ventilator artifact, not periodic discharges or burst suppression. And you get the fluid out of the tube, it usually goes away. Here's an example of the spike and wave. So you can see here it's a sharp wave, then a slow wave, sharp, slow, going at least 6 in a row with no breaks. That's generalized sharp N wave. Here's a less common pattern, periodic discharge going on here in the left parasagittal region, another one in the midline. And by convention, when midline and one lateralized one happen, we call them on the same side. So this is actually a form of unilateral independent periodic discharges, or UIPIDs, if you like to pronounce these things. And here someone sent me this great example of one. There's actually 3 foci, one on the left, one at F4, and then another really slow one at P4. You have to take my word for it that it keeps going. And so this is actually multifocal periodic discharges, MFPDs. This is getting into the plus a little. So this is rhythmic delta, but you see there's some sharp waves superimposed sometimes. So that gets a plus S modifier, which we'll talk about briefly. And here's one. This one is an average reference number. The top half is the left hemisphere, bottom half is the right. So at first you just say, well, there's lowered on the right. But if you look carefully, it's significantly faster at FP2, F4 than it is here in the temporal lobe. And they're actually independent. So you've got 2 foci of rhythmic delta activity in the same hemisphere. So that's unilateral independent rhythmic delta. Okay, I made this point earlier that with focal slowing, it's crucial not to call things rhythmic when they're not. So this is a good example of just polymorphic slowing. It's also called irregular or arrhythmic. They're all the same thing. But this is not RDA. It's not rhythmic at all. And here's an example of what rhythmic delta does look like. This one is, see, a very, very regular, about 1 Hertz lateralized rhythmic delta activity, and this is highly associated with seizures. There's another example of LERTA, so you get used to seeing it. And here's another example of a non-rhythmic one, just focal slowing. Another one, just focal slowing. Another one. I have seen people overcalling any slowing, especially when it's 1 Hertz or high amplitude, they automatically call it RDA, but it's not. It has to be very regular to call it that. So I'm certainly not going to go over all the modifiers, but prevalence is 1. This refers to the percent of the record that's occupied by the pattern. So if you say there's abundant LPDs, that means it occupies between 50 and 89% of the record. Same with duration. That's for each instance of the pattern, how long it lasts. So if it usually lasts between 10 and 60 seconds, we call that brief. We couldn't come up with a good English word for intermediate duration. Then the plus modifier, which is important, does increase the association with seizures somewhat and does get you on the Ichthyl Inorectal continuum, which we'll talk about. So you can have, these patterns can have superimposed fast activity, superimposed rhythmicity, if it's not already rhythmic delta. You can't have RDA plus R, that would be redundant. And you can have superimposed sharp waves, or it can be sharply contoured. And that applies to RDA only. So here's an example of periodic discharges with a little burst of fast activity with each one. That's a plus F. This is one where it is rhythmic delta and it is periodic discharges, and they're both pretty equally prominent. So we just have a rule for that. You automatically, the periodic discharges trump the RDA. So you call this PDs plus R. It's just a rule. When they're equal, you go with that. So this is LPDs plus R. We've defined evolving or fluctuating. They both refer to frequency, location, or morphology. So changes in amplitude alone are not enough to qualify as evolving or fluctuating. And if they don't apply, then it's a static pattern. So evolving, you have to have at least 2 consecutive increases or decreases in frequency, each one by at least half a second, or half a Hertz, or 2 changes in morphology, or 2 changes in location, which each location is a standard 10-20 electrode location. And then just some minor things. If it's evolving and lasts more than 10 seconds, that's the definition of a seizure. If it's evolving, but it's less than 10 seconds, and it reaches more than 4 Hertz, then it's called a bird, which we'll get into. But if it's none of those, if it's less than 10 seconds and never greater than 4 Hertz, then it just gets an evolving modifier. So you actually can have evolving LPDs or evolving LERTA. That's not a seizure and not birds, as long as they're less than 10 seconds and they stay less than 4 Hertz. So here's an example of evolution of frequency, going from 5 Hertz to 3 Hertz to 2 Hertz in 2 different morphologies, just 2 different examples. They both qualify as evolving in frequency. And fluctuating means it goes back and forth in one of those things, but does not qualify as evolving. It's easier with a picture. So if it goes from 4 Hertz to 2 Hertz and back to 4 Hertz and then 2 Hertz, that would qualify as fluctuating, but not evolving. I mentioned we have this stimulus terminated. It's really self-explanatory, but whenever you alert them, if the pattern stops, that's stimulus terminated. And stimulus induced, the one point I'll make is you will often see these patterns spontaneously as well. That's fine, because people have spontaneous alerting and internal things. But as long as you can reproducibly bring it out by stimulating the patient when they're in their unstimulated state, and that qualifies as stimulus induced. And it also includes patterns that are stimulus exacerbated. Sometimes you'll see blunt, slow periodic discharges, then you stimulate them, they get faster and higher amplitude. That still counts as it gets you the SI prefix for stimulus induced. So here's an example of sternal rub bringing out generalized periodic discharges. Here's another one of stimulation causing a focal seizure. You'll see it start here, continues, eventually turns into low voltage fast. So it qualifies as evolving after that. These are usually purely electrographic, but this is one of the examples of actually an electroclinical seizure brought out by stimulation. So you stimulate this patient. At first, it just looks reactive, but it gradually evolves into a definite seizure. And in this case, the patient had finger twitching and opened their eyes and deviated to one side. So you will see clinical seizures induced by stimulation sometimes. It's not rare, but it's much less common than the purely electrographic version. People talk about burst suppression and whether what's in the burst matter, and the answer it probably does. So highly epileptiform bursts were defined. You have to have 2 or more epileptiform discharges in the majority of bursts to qualify. And if they're longer bursts, these discharges have to be 1 Hertz or faster. Or you can have an Ichthyl appearing pattern within the burst. Sometimes you'll see just a miniature piece of a seizure in there. That still counts. So here's examples of highly epileptiform bursts, so multiple sharp waves, or it can be these Ichthyl appearing bursts. We also defined identical bursts. So this has been studied quantitatively, but now we just gave a visual definition where the first half a second of each burst has to be visually similar in all channels in the vast majority of bursts. Doesn't matter what happens after the first half second. So you can see after the first half, it's all different here, but the first half second is identical. So these would qualify as identical bursts. And there's some evidence that in cardiac arrest, having generalized synchronous identical bursts is worse than other forms of burst suppression, but it definitely needs more study. So here's an example of not only, these are all polyspikes, so not only highly epileptiform, but identical bursts. And here's an example where they're identical, but there's only 1 sharp wave in each one. So this doesn't qualify as highly epileptiform because you have to have at least 2. So these are identical, but non-highly epileptiform bursts. Reactivity, I think all EEGers know the definition of that, but it has to be a change in brain activity, not just appearance of muscle or movement artifact. But it can be any change in brain activity, including diffuse attenuation, as long as it's actual brain activity that changes. So you're either reactive, unreactive, unknown, and the only other category is SERPIDS only, which means the only thing you get out of stimulation is one of these abnormal rhythmic or periodic patterns, including IIC or birds or seizures. So if that's the only kind of reactivity you get, that goes in the SERPIDS only category. It stands for stimulus-induced rhythmic, periodic, or Ichthyl discharges. So what was new in this? I mentioned several of these already in the 2021 version. So we added unilateral independent. We added the term state changes, which replaced variability. We added this fairly common phenomenon we see of a cyclic alternating pattern of encephalopathy. We don't know much about what that means yet. Might be even a good sign. It's certainly better than a non-varying unreactive EEG. We added stimulus terminated. We had identical bursts. And then these other ones, we will talk about 3 of these. I don't think I'll have time for the Delta brush. You have to go look at the guideline for that one. All right, so electrographic seizures. This is a big one. Everybody wanted us to find these. We stayed away from seizures in the first version because we tried to stick to purely EEG without requiring clinical correlation. But now there is some clinical correlation when you get to defining seizures. So the purely electrographic version, and this is largely based on the Salzburg criteria, but it is a little different. So you have to have epileptiform discharges averaging greater than 2.5 hertz for greater than or equal to 10 seconds. And the best way to figure that out is to count 10 whole seconds and see how many discharges. If you have 26 of them, that's enough to qualify. If you have 25, it's not. The other way to have an electrographic seizure is any pattern with definite evolution lasting at least 10 seconds. And then electrographic status is defined as electrographic seizure going on for 10 continuous minutes or greater than or equal to 20% of any 60-minute period. So that's new. And the 20% is new. I mean, this wasn't in the prior terminology at all, but a lot of people had used 50% as a cutoff. This got lowered to 20% for qualifying as status. I'll tell you why in a second. This is just showing a picture of a pattern that barely qualifies as an electrographic seizure, because there's 26 of these in 10 seconds. So don't try and count it by looking at 1 second in time. It gets too hard. Just count a 10-second period. So why that 20% rule? Well, it's the Canadians' fault. So this came out of Toronto from sick kids. So looked at 260 pediatric ICU patients. You can see how often seizures were seen, neurologic decline in 2/3 of the patients. But they found that the maximum hourly seizure burden was important. And if that was greater than 20%, which means 12 minutes out of a 60-minute period, then there was a really large jump up in the chance and the severity of neurologic decline. It was not mortality, but it was neurologic decline. So this is a bar graph from that paper showing the maximum hourly seizure burden and the chance of neurologic decline. You see this huge jump up where virtually all the patients had neurologic decline once they got over 20% burden. So this is also true in adults, by the way. Seizure burden is related to outcome. Probably the best study was this subarachnoid hemorrhage paper, looking at all non-convulsive seizures. And at 3 months on multivariate analysis, they found that seizure burden, that's the percent of time they were having seizures, was associated with disability, mortality, and cognition, all in separate analyses. And this comes from that paper. As the hours of non-convulsive seizures go up, the probability of unfavorable outcome on the modified Rankin goes up in this shape, and a cognitive score on the telephone interview of cognitive status decreased pretty linearly with the number of hours of seizures on EEG. So there's not so much a marked cutoff just at one point. There seems to be a pretty consistent relationship with higher seizure burdens, worse outcomes. And that's been shown in many studies. I'll mention 2 that came out very recently. This is a pediatric one, so even bigger, coming out of CHOP in Philadelphia. 700 critically ill patients, electrographic seizures in 20%, status in 6%. And in multivariate analysis of functional decline, electrographic status had an odds ratio of 2.2. So you were more than twice as likely to have functional decline if you had status. And you can see the other odds ratios, the other things that were significant. Individualized seizures were not associated with outcome, but status was. It had to be prolonged or a high burden. And then they looked at a whole bunch of different subgroups, and all of them still found electrographic status to be an independent predictor of poor outcome. And then out of Mass General in Boston, in adults, published in Annals, they looked at this automated detection of highly epileptiform patterns. So this included all the periodic discharges and lateralized rhythmic delta and IIC and seizures all combined. Not just sporadic discharge. It had to be one of the highly epileptiform patterns. And they looked at a bunch of measures of seizure burden. They actually found the one that was best was the highest 12-hour seizure burden. So that peak burden was a strong predictor of outcome. We see a hugely significant p-value and in a clear dose-dependent manner. And they pointed out that an increase of epileptiform burden from 0 to 100% increased the chance of poor outcome by 35%. These graphs are from their paper showing in all these different groups. So any acute brain injury, cardiac arrest, just acute seizures or status group, and even systemic illness, the peak 12-hour burden of epileptiform activity, including seizures, was associated with the probability of poor outcome. A very nice study with automated data and very large numbers. All right, back to definitions. Electroclinical seizure is also defined. So that's any EEG pattern that has a definite clinical correlate that's time locked to the EEG pattern. So it can be any duration. This could be 3 seconds. If you've got focal twitching or eye deviation or aphasia that is clearly time locked to a pattern, then that's an electroclinical seizure. The other way to qualify as electroclinical seizure is to show EEG and clinical improvement with an IV anti-seizure medication. Note the EEG pattern itself does not have to qualify as an electrographic seizure. And then status is defined the same way as electrographic, 10 continuous minutes or greater than 20% of any hour. The only exception to clinical status is if it's bilateral tonic-clonic, you only need 5 minutes. That's the ILAE definition of convulsive status. But for all other seizure types, you need 10 minutes. All right, getting on to the difficult ones. This is the Ichthyl Inorectal Continuum. So this is really a synonym for possible electrographic seizure or status. So something on the IEC is a pattern that doesn't qualify as definite seizure, but it's something where there's still a reasonable chance it could be causing clinical symptoms, including impaired alertness, or it could be contributing to neuronal injuries. So that's the concept. So it's potentially Ichthyl in some sense, either contributing to clinical impairment or to neurologic injury. And they often warrant a diagnostic treatment trial, usually with an IV anti-seizure medication. We try to avoid giving benzos first. We try the non-sedating ones first. You have a much better chance of seeing a clinical improvement. All right, so it's defined as any periodic discharge or spike wave pattern that's between 1 and 2.5 hertz. It has to last at least 10 seconds. Or it can be a little slower, between 0.5 and 1 hertz. But for that, it also needs to have a plus modifier or fluctuation. And lastly, it can be lateralized rhythmic delta that's greater than 1 hertz with a plus modifier or fluctuation. And that's any lateralized rhythmic delta. It can be bilateral independent, unilateral independent, etc. Note that generalized rhythmic delta activity is not part of the IEC ever, as it has not been shown to be associated with seizures at all. And notice that it cannot qualify as definite seizure activity. Then it's seizure. It's not IIC, it's just seizure. So here's some examples. This is a right hemisphere IIC pattern. It's really periodic discharges with some superimposed rhythmicity. It's at about 1.5 hertz. And here's a generalized version, a little uglier, a little higher amplitude, a little faster, still though less than 2.5 hertz. So it does not qualify as definite electrographic seizure. You may decide to treat it as a seizure, but it doesn't qualify as definite electrographic seizure, so it's still on the IIC. That's how we would describe it. So if you have one of these patterns on the IIC, it's lasting at least 10 minutes or more than 20% of an hour. You give IV anti-seizure medication. The EEG pattern improves, but the patient does not. That's what's called possible electroclinical status or possible non-convulsive status if you prefer. But basically, you didn't learn anything with that trial. You're basically right where you were before you did the IV med trial. You still don't know if it's a seizure or not. It still could be, but you haven't proven it. So again, notice this cannot include patterns that are definite seizure just on their own. So those are just electrographic seizure. This is only for the equivocal ones on the IAC. People have tried to pin me down on exactly what patterns I would treat. So this is my oversimplified answer. Treat definite seizures, though there are many patients in like prolonged refractory status where we will tolerate a low burden of seizures, especially if they're brief and you've tried a lot of other things and they're not getting more and more prevalent. As far as periodic discharges, I do in general treat patterns that are sustained at 2 hertz or faster. So that's kind of within the IEC still, but once you get to 2 hertz or faster, we will usually treat them. For most other people on the IEC, I recommend a diagnostic trial. And then for tough cases, we use all these kind of imaging, serial neuron-specific enolase, et cetera, to try and figure out if they're causing neuronal injury. And we do incorporate some of those things in our decision making. So why that 2 hertz cutoff? Well, we had been doing that for a long time, but finally there was actually some objective evidence from it from this study. This was in comatose subarachnoid patients getting invasive monitoring, including depth electrodes and tissue oxygen measures through a Lycox in the brain parenchyma. And what they found was that as the frequency of periodic discharges increased from 0.5 hertz to 3 hertz, there was increased cerebral blood flow, but the tissue oxygen started to drop and it reached hypoxic levels when the periodic discharges got faster than 2 hertz. I'll show you a bar graph from there. So this is the tissue oxygen level, again, in the brain parenchyma, and this is the frequency of the periodic discharges. You see it starts to drop by 2 hertz, and it reaches significance by 2.5 hertz. So it's limited. It's one paper, and it's based on invasive monitoring, but since it matched what we were doing clinically, we continue to use that as our general cutoff. So they concluded that in comatose subarachnoid patients, the brain can compensate for increased metabolic demand up to about 2 hertz, but not faster than that. Okay, here's your next quiz question. In a 1-hour EEG recording with many 1-minute electrographic seizures, how many total minutes of seizure activity are required to qualify as electrographic status according to the ACNS guideline? So how many minutes out of 60 minutes? Give you 5 more seconds. I saw a good amount of B's for 10. It's close, but most people got it right. The correct answer is C, 12 minutes. Yeah, that's 20%, right? 10% of 60 is 6, so 20% is 12. 12 minutes out of an hour would qualify as electrographic status. Okay, next question. Which of the following patterns is not on the Ichthyl Inorectal continuum? I'll let you read them. It's not ideal because people can see other people's answers and get swayed. Five more seconds. Okay, the answer is B, and that's because GPDs at 3 hertz qualifies as electrographic seizure. That is not on the IC, it's just seizure. All the others are actually on the Ichthyl Inorectal continuum. Okay, next question. An IV anti-seizure medication is given for more than 1 hour of 1 to 2 hertz GPDs plus R. Okay, so we'll just tell you it's on the IIC. The pattern resolves and the patient begins to follow commands. This is best referred to as which? A little more variable in the answers this time. All right. I think the crowd still, by crowdsourcing, you got the right answer. If the answer is C, electroclinical status epilepticus. So it doesn't qualify as electrographic status. It's a little too slow for that. Yes, it is true that it's on the IAC, but now that I gave you this clinical response, the better answer is electroclinical status. Possible electrographic status, that is true, but you proved it was by this test, so it's not possible anymore. And same with E. So you got rid of the possible by proving this was electroclinical status with your IV anti-seizure medication trial. All right. All right, a little bit about birds. I think that's the last pattern I'll be defining and going over. So this is mostly, Jenna Yu has published all the papers on this. I was involved with most of them. The original definition is this one back in 2014, less than 10 seconds, rhythmic activity greater than 4 Hertz with or without evolution. It was usually theta and sharply contoured and usually only a few seconds. And in this paper, 75% of patients with birds had electrographic seizures compared to 25% of matched controls in this critically ill population. They were mostly non-convulsive seizures. Birds came before seizures in almost all cases, so it was a harbinger that you're about to see seizures. And birds went away in every case in which the seizures were fully controlled. She did a paper in non-critically ill, so this epilepsy monounit patients or people getting ambulatory EEGs. And birds, again, were mostly less than 4 seconds. And patients who had birds were more likely to be refractory. So 67% of them had refractory epilepsy compared to 17% of the matched cohort. And birds always came from the same location as the seizure, usually had the same morphology as well. And then in this paper, we defined a more specific definition with some subcategories that became part of the ACNS definition. So this is the ACNS definition. Birds are defined as focal or generalized rhythmic activity greater than 4 Hertz. And as with every other pattern, you have to have at least 6 waves to count. This is less than 10 seconds. It cannot be a normal variant, so don't call RMTD or Wickets birds. It can't be part of burst suppression, then you just call them bursts. It cannot have a clinical correlate, because if it had a definite clinical correlate, it would be a seizure. And it has to have at least one of the following features. Okay, evolution, so that's evolving birds, and those are definite. The similar morphology and location as interictal epileptiform discharges in that patient or seizures. That's also definite. And it can be sharply contoured, but without either of those. And that's not as possible birds, not yet as clear of the really high association with seizures. So note paroxysmal fast activity, including just bursts of polyspikes that last less than 10 seconds, qualify as birds. So generalized paroxysmal fast activity, as long as there's no clinical correlate and it's less than 10 seconds, is a generalized bird. And then also note that although they're called brief, by definition, they're actually all very brief. They have to be less than 10 seconds. So we didn't want to call them V birds though. They're just birds. So here's some examples. This is actually 2 different birds on the same page. It's about 5 Hertz, sharply contoured, and it's got the same location morphology as some interictal discharges in this patient. So that becomes definite. Here's another one of evolving birds. It's like a 4-second little evolving pattern. Also definite since it's evolving. And here's some who has sporadic birds and then a seizure all on the same page. You have to take my word that this last one lasted more than 10 seconds. And this is birds during the pandemic. All right, so we did inter-rater agreement on the old version. which actually had already gone through about 25 revisions and presentations at meetings and things. And in the end, it was actually very good for the main terms, and many of the modifiers had very good agreement. Evolution and triphasic and some things did not have great inter-rater agreement. The evolution, I think, was because the clips were too short. Then there were lots of studies using all this terminology. Here's an example study in highly epileptiform bursts. So this was people with refractory status being treated with barbiturates. And when trying to wean the anesthetics, if you had highly epileptiform bursts, 11 out of 17 of those went back into status. Whereas if you had non-highly epileptiform bursts, they all were successfully weaned at that point. So here's an example from their paper. The same patient at 2 different time points. Here they were weaned and they failed, went back into status, and then later their bursts looked like this, and they were successfully weaned. Lateralized rhythmic delta has been studied a few times now. In our hands, lateralized rhythmic delta actually had the exact same association with seizures as lateralized periodic discharges. In fact, slightly higher, 63% versus 57%. This is an example. This is the lateralized rhythmic delta in a patient. And that's not seizure itself. It's a marker they're prone to seizures. And here's a seizure coming out of the same location, much faster frequencies and evolving definite seizure. You can see this is LERTA compared to LPDs in our series. The first bar includes clinical seizures. The second is only during EEG monitoring. And you see if you just have focal slowing or none of the above, the rate of seizures was 20% or lower. Then we did this very large multi-center study, 3 centers that were using the centralized database for clinical care. And this is kind of the summary. So lateralized periodic discharges were always above the significant risk level. But as the frequency of the pattern increased, so 2 Hertz LPDs had an even higher association with seizures than 1 Hertz. And for LERTA and GPDs, they only reached significance when they got to 1.5 Hertz or faster. Again, generalized rhythmic delta had no association with seizures. And these 2 lines of each one are showing that the plus modifier had an even higher association, statistically significant, with each one of these patterns. Not a huge difference, but a significant one. So prevalence mattered. Look at GPDs, for example. If you go from occasional to frequent to abundant, there was a higher association with seizures. Same with LPDs. Whether a pattern was stimulus induced or not didn't seem to matter. At least with GPDs, there was no difference at all in the rate association with seizures, whether it was stimulus induced or not stimulus induced. There's still more research needs to be done on a lot of that and is going on. So do these modifiers matter? So I like this study because they actually looked at the modifiers. There's 100 patients with periodic discharges with controls, and they looked at outcome. Mortality and disability was higher if you had periodic discharges, and they were independent predictors of poor outcome. But maybe more interesting, they also had more epilepsy. 48% in the group with periodic discharges developed epilepsy. But LPDs plus had a higher risk for later epilepsy than LPDs without the plus. And again, the prevalence mattered and the duration mattered. It's in proportion to long-term outcome. So it shows these modifiers actually have some association with long-term outcome. So conclusions, and I do have some more quiz questions if we don't have questions. There's an ACS guideline. There's a separate neonatal version. Many terms are now defined. Many at least have some scientific evidence now, but many still do not. Most have not been adequately studied. We need large series and specific diagnoses, for example. The new version includes definitions of seizures, status, BIRDS, IIC, etc. This is all on the acns.org website. If you go into the guidelines section under the continuous EEG monitoring, it's also in Journal of Clinical Neurophysiology. And on the website, there's a reference chart, there's an abbreviated version, there's EEG examples, there's a full PowerPoint training module that includes a lot of the slides I just showed you. And there's a self-assessment examination that will give you a certificate at the end if you pass. Make sure you do that training module first, or you probably won't pass. So that's all available now on the ACNS website. Seizure burden matters, and the frequency of periodic discharges matters. The faster, the worse, both acutely, based on brain physiology, and for longer term outcome. And with that, I will stop with a pretty picture from the Connecticut shore of our epileptologists. So thank you, and let's see how you want to do the questions.
You can put that in the chat or.
Okay, I'm going to stop sharing. Well, maybe not. I'll leave it on. Yeah, so I see some questions. I'll have to start at the end. Yeah, so
I will read out the questions for you, but if you have any anything to ask the audience, this is the time. Otherwise, I will take over.
why don't we do the questions first?
Okay, good. You want to unshare your screen?
Sure.
Thank you, Dr. Hirsch, for that wonderful talk. And on behalf of the Canadian Epilepsy Teaching Network of the CLA, and my colleagues in the committee, Dr. Eileen Reed, Esther Bui, JP Appendino, Tad Fandanianu, Kevin Jones, and Eliane Kobayashi. Thank you very much. And thank you for all the people who attended from within North America and around the world. We had around 140 people attending live at one time. And this will be available in the website of CLAE, and it is free. It will be uploaded within a week. One more housekeeping rule that next month on March 18th, we will have the talk from Dr. Federico Polo on multimodal neuroimaging in epilepsy. And as you are aware, Canadian Epilepsy Teaching Network is also involved in teaching EEG for senior neurology residents and epilepsy fellows. And the last year it was a success, and we will be restarting the course next month. With that, I will take up the questions. But before that, Dr. Hirsch, I have a question. So these EEG patterns are fantastic. You need very careful analysis in an ICU. So resource-wise, probably at the end of the day, what matters is whether you can actually pick up seizures, which is a treatable item within the PICU. There is continuous monitoring, but only intermittent analysis or reviewing. So how do you sort that out in your ICU setting? Do you train nurses, or do you use any software or any other tools?
Yeah, great question. Yeah, absolutely. Just putting electrodes on the head is not going to help the patient if you don't look at it and act on it. Even though a study actually did that, which we'll talk about. Yeah, so we do have it piped into where we have a monitor watcher looking at all our screens continuously. And we do have seizure detection software running on it. Having said that, we don't always have people who really know how to read EEG looking. There's a huge shortage on EEG technologists, and expensive to find good ones, and to have them there 24/7 is very few places have that. There certainly are some, but very few. So mostly it's looking intermittently. But if you can review it every 4 hours or so, that's still dramatically better than not detecting them at all or detecting them 24 hours later. And then it depends on the, in our place, we leave it running at the bedside as well. So the raw EEG and the quantitative are there, which has the seizure detection. And we've trained our residents and neuro ICU fellows on how to read EEGs. So they do all the middle of the night work. And then the daytime, we keep a much closer eye on it. But it's far from perfect, but we're getting closer and closer to really continuous live seizure detection in our critically ill patients.
Okay, I will go over the questions which is already posted. So how can we define electrographic seizures with the generalized epilepsy such as spike and slow wave complex in train? And this is from Tanya. So probably what she means is if there is a generalized pattern, how can you say that is a seizure? Probably you already answered that if the frequency is more than 2.5 and what happens if it is less than 2.5, maybe you can elaborate on that, Dr. Hirsch.
Yeah, I'm not sure if this was related to the question, but the only exception is people who have a prior epileptic encephalopathy. It has to be different than their baseline EEG, both clinically and electrographically, to call it status. So some of those get very tricky because some of those patients look like they've been in status their whole life. So we like to see both a clinical and an EEG difference from their baseline.
Okay. The next one is from Dr. Sriram Ganti, and he is asking, what about the seizure type? So probably what he means is multifocal or hemispheric or generalized electrographic seizure in relation to patient outcome.
Haven't seen much about that, the location and predicting outcomes. Mostly been seizure, yes or no. So I don't think there's any good data to answer that one.
Okay.
I mean, they're all virtually all focal onset seizures, but whether they're multifocal or they spread and look generalized, yeah, that definitely happens. So I don't have a good answer for that.
Okay. I'm just scrolling through the questions because when you ask the questions, what I'm seeing is all the responses. Okay. Another question is, can the Bird's nomenclature be used for intracranial EEG as well?
Yeah, yes, we do use it for intracranial. Almost all epilepsy patients have Birds when you look intracranially, the vast majority of them. But yeah, if we see little seizures that last 6 seconds, we call them Birds instead of seizures. But
okay,
largely semantics, but they are very useful. Yeah. They still tell you where their seizures.
But if you put your stereo EEG into a focal cortical dysplasia, will you see this rapid firing?
Well, most commonly you see periodic discharge or continuous periodic discharges. How often do you see continuous Ichthyl discharge? You certainly can.
Okay.
I mean, it certainly wasn't meant for intracranial use, but we do use it for that.
I think probably you already alluded to this. Does ACNS terminology apply to neonates? I think you mentioned there is a specific guideline.
There's a separate neonatal guideline, right?
Okay.
Someone else answered it.
Yeah. From Jeffrey Hirsch, can Dr. Hirsch please comment on Rossetti's randomized control trial published in JAMA Neurology last year that did not find a significant difference in clinical outcomes at 6 months between continuous EEG and routine EEG? Is there a need for further RCTs in this area?
Yes, thanks, Jeff. Jeff and I have worked together on writing stuff on non-convulsive status. So the Hirsch and Hirsch combo. Yeah, so thanks for asking that. So there was a trial, Andrea Rossetti in Switzerland did this trial of randomizing people to continuous EEG versus daily routine EEG over a couple of days. And they showed basically no major difference in outcome. So there were a lot of major problems with it. And this is the one I was referring to. I said there was a study that basically looked at whether putting leads on the head made a difference or not, but they didn't act on it because they didn't look at it. There was no monitoring overnight in that study. So the seizures, they obviously couldn't act on them in a timely manner. The other thing is their primary outcome measure was mortality. They did have a tertiary outcome measure of outcome at 6 months that showed no difference. So there was a trend towards a difference in the non-cardiac arrest group, favoring the continuous EEG. The other key points on that study was they excluded anyone with prior seizures because they thought they warranted continuous. So that's an important point. They would not have been randomized in the study. The other thing to realize is the rate. I'm trying to find the exact number of how many actually. So seizures were detected on the routine EEG in 8%, but on continuous in 29%. So you'll have a marked increase in your detection of seizures with the continuous. Changes in medications only occurred in 21% of the continuous EEG patients. Okay, so 80% of the patients who got continuous had no treatment changed. So that means 80% of the patients had no chance of an improved outcome because nothing was done to them except putting leads on their head. So that's what should have been used for the power calculations and determination of outcomes. So it was dramatically underpowered to show any difference from that. So you have to do it right. You have to be doing continuous monitoring. You have to be able to act on it, and you have to treat them, or you have no chance of showing improvement. And I guess the last point I'll make is there was a huge delay in hooking up EEGs. They were hooked up a median of 2.5 days after they were admitted. Whereas in prior studies, including most of the ones from North America, it's more like 1 day or less than a day. So to me, I say this is like taking acute stroke, studying TPA or thrombectomy, but not doing your consult until 2.5 days into their admission and not being able to do any intervention overnight. And so obviously you would have concluded it's not worth doing. So
yeah,
that's my opinion on that study.
We have reached 1 o'clock. So I think Dr. Esther Buie has a question. Esther, what is your question?
So thank you for being the highlight of my week, being a self-confessed EEG nerd. It's such a privilege to hear you talk, Dr. Hirsch. I'm actually interested in education, and my question is in resource poor areas, and you don't have to go far from Toronto to be resource poor when it comes to EEG. Where do you see the future in terms of either enabling intensive care programs or education training programs to really bridge that gap? And it's an urgent need.
Yeah, I think education, as long as you have internet access nowadays, the education part is pretty easy. Programs like this, including when you post them. I don't know if people are aware of the EEG talk series. I've basically gone over this talk over a series of short videos with the EEG talk program on YouTube that's run by Fabio Nascimento and Brandon Westover from Mass General. So they're very entertaining too. They add lots of sound effects and things. Check those out. ACNS has all kinds of educational things, both posted twice a year. They have courses. And so I think that part's easy. It's the hardest part is getting EEG in these areas with limited resources. And that's where I think all these rapid EEG devices are going to really help, where you don't need a trained EEG technologist hired to do them. They're still costly at the moment, but they're a lot cheaper than hiring somebody. So if we get those rapid EEGs, those are things that can be done anywhere with like a 15-minute training. And you have some kind of network of EEG readers, which is also very easy. It's very logistically an issue, but there's no technological barriers to that. So we should be able to do all that. The cardiac people, as usual, are way ahead of us on doing those things, but we're getting close.
Yeah, so I'm a big fan of Fabio Nascimento. His YouTube talks are fantastic. Yeah, so with that, I think we'll close. Thank you so much, Dr. Hirsch, once again for a fantastic talk, and hope to get you back sometime in the future too.
Thank you very much. Happy to come back anytime.
Bye-bye. Take care.
Bye, everyone.